Good evening and welcome to the South African Medical Association webinar on COVID-19 vaccines. I'm grateful to everyone who has made time to join us for this important discussion, particularly our two guest speakers, about whom I will speak a little more in detail about later. I also would like to thank colleagues out of South Africa, that's not in South Africa, as I believe there's colleagues from other countries also joining us. You are most welcome. And thank you so much to all our other non-SAMA members who are either joining us again for insight on an important topic or who are joining us for the first time. We are extremely happy that our webinars are available online through the marvel of technology, which is allowing us to broaden the reach of these sessions, and in doing so, extend the knowledge available to doctors throughout the country. Our aim with these webinars is to provide the best information possible to you. And I believe that we are doing exactly that with the excellent caliber of speakers we are able to source for these events. A bit of marketing, but because what are SAMA without marketing? If you are not yet a member, please get in touch with us on 012-481-2071 for more information. Remember, SAMA plays an active role in advocating for the rights of doctors and unifying of the profession for the health of the nation. So, if you are not already a member, please review our benefits and services and join the largest and oldest medical association in the country. Our topic tonight is an incredibly important one, and obviously quite timely, given recent developments in the search for a COVID-19 vaccine. How far have we really come? And is there hope that the vaccines we are hearing about will really deliver on their promises? Well, that is part of what we are here to find out tonight. But because of technical problems, Prof. Madhi will start just after 7 o'clock, and we are going to be joined now tonight to talk about the ethical aspects of vaccines. And one of South African leading experts on bioethics, Prof. Ames Dhai. Prof. Dhai is the founder and past director of the Steve Biko Center for Bioethics at the University of Witwatersrand, visiting professor of bioethics and law at the School Health Law at the School of Clinical Medicine, also at WITS, and specialist ethicist at the Office of the President. As if this wasn't enough reason to include Prof. Ames Dhai in tonight's webinar, let me add that she's also the president and CEO of the Medical Research Council and a member of the Academy of Science of South Africa. She's an honorary professor in the College of Human and Health Science at Swansea University in the United Kingdom. Chairperson of the National Bioethics Committee of UNESCO National Commission, and on the SAMRC Bioethics Advisory Panel. An accomplished academic, Prof. Dhai is editor-in-chief of the South African Medical Journal and has been published extensively in the field of health advocacy and activism. Again, it is a privilege to host Prof. Dhai here tonight, and I'm certain that her speech will provide everyone present with unique and valuable insights into the ethical aspects of vaccines. Again, at an incredible, opportune moment in the world's history. I also would like to tell you that Prof. Ames is so-called retired. But if you look at what she's currently doing, I think she's more busier than ever. And she wanted to go and look after her grandchild. I think the grandchild will look after Prof. Ames at this tempo that she's taking, going to take to the to all the hard work that she's doing in her retirement. Just to let you also know, before I get to Prof. Ames, our evening tonight will be moderated by Ms. Shelley McGee from SAMA's Knowledge Management and Research Department. Thank you, Shelley, as always, for assisting with this task. And I would also then like Prof. Ames to start. Prof. Ames, the floor are yours. Thank you.
Thank you so much, Dr. Kutsia. And thank you for elevating my status, because I'm not specialist ethicist at the Office of the President. I'm specialist ethicist at the Office of the President and CEO of the MRC. Professor Glenda Gray remains President and CEO of the MRC. So just to clear, to clear that, I haven't reached that status as yet. But thank you so much for the warm introduction. I would like to share my screen, and I'd like assistance from your end in terms of, right, okay, there you are. So I'd like to thank SAMA for inviting me to talk this evening on, like the chair said, a very, very, very important topic, and that's COVID-19 vaccines. And I'm going to discuss some of the ethical considerations. There are a number of ethical considerations, but I'm just going to limit, because of time limits, I'm going to limit myself to some defined ones. So by way of outline, I'm going to discuss our increasing numbers, vaccine hesitancy, vaccine nationalism. I'll say a few words on what Africa CDC has been doing with regard to vaccine development and access. I'll also say a few words on the fair allocation framework based on African indigenous values that the MRC is working on, and a little bit about implementation. So what's the situation? Early on in November, we could see that the new cases in Africa had increased by 20% and the deaths by 26%. It hasn't changed, it's actually increasing even more. And there were 5 countries that actually were responsible for more than 75% of the new cases and deaths. And South Africa was listed amongst these 5 countries. When we look at our most recent stats, as you can see, we gone well above the 4,000 mark in terms of numbers, and that really is of concern. And why are our numbers increasing? Is it because there's COVID-19 fatigue? Is it because we have certain members of the population that are just irresponsible? And we've seen what's happened with all the rage, matric functions that have been happening, and these have proven to be super spreader events? And is it because we just haven't managed, especially with certain parts of our communities, we haven't managed to communicate the issues in a language that our communities would understand? However, when we look at the fact that so many are not going the preventative route, not using masks, not social and physical distancing, not washing their hands, not using the sanitizers, I think you will agree with me that vaccines are a very important tool for COVID-19 control. Now, if we do have vaccines, and if we do have the vaccine, COVID-19 vaccine, come across to us, we need to have it within the framework of a program. And the goal of that program must be that of decreasing morbidity and mortality. But it doesn't just stop there. We've seen how society and our economy has been disrupted as well. So the goal of that program should also be to minimize disruptions to society and our economy. And it's really concerning that the World Bank predicts the first recession in 25 years in our African region. So how do people feel about using a vaccine? Survey done globally by the World Economic Forum found that 75% of adults globally felt that they would get a vaccine for COVID-19, whereas 25% felt they would not. And it is concerning, the 25%, because, what would this do to us in terms of herd immunity? Would we ever be able to reach it? What's the situation in South Africa? Very early on in October already, a study showed that less than 2/3, that's only 64% of South Africans were going to accept a COVID-19 vaccine when it became available. And of that 64%, only 29% strongly agreed to the vaccine, whereas the rest just somewhat agreed. And this is worrying. And then as we started getting the vaccines, the news of the positive results of the vaccines being announced, we started getting misinformation of this nature going viral on social media. And this definitely also would hurt vaccine uptake. So what are some of the reasons for vaccine hesitancy? It could be because of the novelty of the disease. And before I actually go into the reasons, what's the difference between vaccine hesitancy and anti-vaxxers? So anti-vaxxers are very clear. They are totally against vaccines. Vaccine hesitancy is, I may or I may not, I'm not too sure. So I'm hesitant to take the vaccine. So that's the difference. And why do we have this hesitancy? It's because novelty of the disease, the unusually rapid speed of the vaccine development. This may be a problem. People can't grasp that this could actually be safe because it's actually happening so rapidly. Mistrust of science and of health experts by some. I've talked about COVID fatigue. There could be an emotional detachment due to this fatigue. And because of the infodemic, there is so much information sort of causing a tsunami within our heads. The uncontrollable nature and prolonged uncertainty of the pandemic, this is of concern as well. And then we've got politicization of the vaccine and its safety and efficacy standards. And you'll find this by some groups. And then, of course, there's the conspiracy theories by the anti-vaxxers. Now, within South Africa, in the study that I discussed, distrust in the vaccines actually mirrored a lack of trust in public health institutions. And it was found that 32% of South Africans said they had no trust in hospitals and clinics. So, how is this vaccine misinformation going to be handled? Well, in Africa, there's been a move towards this. And on the 3rd of December, the African Infodemic Response Alliance, the AIRA, was launched. And basically it was launched to coordinate actions and pool resources to combat misinformation around COVID-19, the pandemic and other emergencies that actually come through in Africa. And when you look at what they report, that between February and November 2020, there were over 270 billion views online about information of the virus. This had been shared and viewed, over 270 billion. And it was mentioned 40 million times on Twitter. and web-based news sites. And this was only in the 47 African WHO African region countries. Okay, so you can imagine how much more there is globally. And what was also found was that a large proportion of this information was inaccurate and misleading. And despite that, it continues being shared by the social media. And it's been shared and used either intentionally or unknowingly on a daily basis. And while this infodemic is amplified through social media, they found that health misinformation was also circulating quite rapidly offline as well. Organizations in Africa were able to debunk more than 1,000 of these misleading reports. And to quote Dr. Moeti, who is the WHO Regional Director for Africa, what he said was, quote, "In health emergencies, misinformation can kill and ensure disease continues to spread." And this is what we've got to be very careful about with the COVID-19 vaccine misinformation that's doing its rounds. This can result in deaths for many. And he talked about the glut of information, this infodemic that we have. And basically, you know, I think it's really good that we've got this network that's just been launched. It's a positive way forward in terms of debunking some of the myths. And it is the first initiative of its kind. And it brings together 13 international and regional organizations and fact-finding groups. And they are basically going to address communications. They're going to detect, disrupt, and counter damaging misinformation on public health issues here in Africa. So let's move on to vaccine nationalism, coined as vaccine nationalism in this study that I have on the slide. And this study showed that, you know, rich countries, as soon as the vaccine started, you know, being developed, the manufacturers started talking to different countries. Rich countries went and, like the study says, on a shopping spree for COVID-19 vaccines. And what would this mean? That it would be fewer vaccinations for us in low-income countries. And that's for billions of people around the globe. And the analysis, which was done by Duke Global Health Innovation Center, showed that the way these countries had pre-purchased, that they would be able to vaccinate their entire populations over and over again, well before billions of us in lower income countries actually get vaccinated. And when you look at the United States, it's already purchased 230 vaccines to inject 230% of its population, well beyond the 100% mark. And actually, data from the study showed that several COVAX signatories, I'll come back and give you some detail on COVAX, but COVAX is spearheaded by the World Health Organization, and it's basically trying to promote equitable access to vaccines globally. And many countries like the United Kingdom, the EU, and Canada, who are strong COVAX signatories towards global health vaccine equity, they actually undermining this pact that they signed into by negotiating side deals for these large vaccine shipments that they are ordering. And on this slide, you can see that you can have a look at which countries have pre-ordered vaccines, and you can see the EU has really ordered in huge quantities. And if we look at these countries, in Africa, there's no country that's pre-ordered. And we can say that we wonder whether countries in Africa have even started window shopping. While these countries have gone on a shopping spree, we haven't even started window shopping. So what is COVAX? It's a coalition led by the World Health Organization, the Global Alliance for Vaccines and Immunization, Gavi, and the Coalition for Epidemic Preparedness Innovations, that's the CEPI. And basically, it's a working group for basically it works towards global equitable access to the vaccines. And therefore, it's been established to counter vaccine nationalism. But is it actually being successful in countering vaccine nationalism? No, because countries that have signed up into COVAX have actually gone on this shopping spree. So one wonders how it's actually going to achieve its goals. It's basically a global risk-sharing mechanism where it pools procurements towards equitable access. It's arranged for advanced market commitments for lower income countries, and these lower income countries will get the vaccines at a lower cost, but these will be funded through official development assistance or through philanthropic organizations. Now, where's South Africa? South Africa is not considered a low income country. South Africa is considered to be a middle income country. And according to COVAX, South Africa can be self-funding. And it can self-fund to the extent that Japan, the EU countries, the UK actually self-fund. So South Africa is actually placed on that level when it comes to what it's going to be paying for the vaccines. Forget that we injunct status. So the financing and pricing mechanisms of COVAX is quite obscure, and it's quite, I would think, lopsided as well. And also the volumes that are going to be available to countries isn't that clear-cut at the moment. And I've borrowed the slide from Tian Johnson, who presented at the National Bioethics Committee of the UNESCO webinar on the very same talk, COVID-19 vaccines, access and equity, presented 2 weeks ago, and he kindly gave me permission to use his slide. And he's from civil society. And what he presented was that they found that COVAX was so highly resistant to engaging with independent civil society. And it was only after months of lobbying and infighting did they include civil society on the COVAX structures. And the question that he asked was, and I'll quote, how will this powerful and well-resourced, unelected structure be held to account? And we put money into COVAX. How is it going to be held to account? Because he asks who elected COVAX. So let's move to Africa. What do we see in Africa? So the African Union and Africa CDC convened a meeting in June, and they had about 3,000 high-ranking officials and stakeholders looking at the approach for vaccines, COVID-19 vaccines. And through that interaction, the Africa CDC developed the COVID-19 vaccine development and access strategy and launched it in August. And the focus of the strategy is to prevent transmission, prevent deaths, and prevent social and economic harm. Its key objectives are to accelerate African involvement in the clinical development of a vaccine, to ensure African countries can access a sufficient share of the global supply of vaccines, and to remove barriers to widespread delivery and uptake of effective vaccines. So it's work in progress. How are they going to take this forward? So an African consultation has been planned, a follow-up African consultation has been planned for a week from now, 14th and 15th of December. And this consultation is going to work with African voices for Africa on a framework for fair, equitable, and timely allocation of the vaccines. And this is a collaboration between the South African Medical Research Council and the Africa CDC. So this is how this is being taken forward on the continent. What's been happening to us in South Africa? We haven't had really much in terms of communication. And I must say that in South Africa, that's not something we can rant and rave about in terms of us being expert communicators, especially from the level of decision makers. So on the 25th November, we saw a press report where our finance minister had already stated that South Africa paid 500 million for access to COVID-19 vaccines, and billions more had been budgeted. And I remember listening to the media report the night before. It was on national TV, and a figure of 4.5 million had been quoted. But this then clashed with what had been stated on the 24th of November. So it was around the same time by Department of Health. So Department of Finance was not talking to Department of Health. And Department of Health said that South Africa had not yet signed the commitment agreement to participate in COVAX because it had to complete the necessary administrative processes. It was only going to do so once officials had attended to this. So fast track forward to 4th of December, there's been a press release from the Department of Health, which announces, and this follows President Ramaphosa's announcement from earlier on in the week, where he stated that 327 million was going to be paid into the COVAX facility. And this press release confirmed that the COVAX facility was going to be engaged with and vaccinations for at least 10% of South Africa's populations was going to be ordered. It went on further to say that the first tranche of the payment, which is actually the down payment, would be in by the 15th of December. So we still haven't paid. And this down payment is the 327 million that the president had alluded to. And this is a payment being made by the Solidarity Fund towards vaccines for our populations. Now, the full cost of purchasing the doses for the 10% is over $2 billion. Now, this is just the vials, the cost of the vials. This has nothing to do with transport, shipment, and administration, etc. And if you actually do the maths in terms of all this, it's going to cost about double the amount for 10% of the population. So it's something for us to think about. In addition, what the report said was that we expect to receive that first batch of the stock in the second half of 2021. Now, that announcement went on further to say that other countries were also doing research on the vaccine. There were 4 vaccine trials happening in South Africa, and other countries and other vaccine trials would also be considered in South Africa. And so the Department of Health was going to engaged these vaccine manufacturers. So they want to reassure South Africans that while COVAX is its favored vehicle, it will look at at other manufacturers or go directly into deals with manufacturers as well to ensure that it can get enough vaccines to roll out, and also it will look at cost effectiveness of this as well. I think very important in that message was that collaboration between the private and public health sectors will be key to successful implementation of this life-saving intervention. And I see it from two perspectives. I see family practitioners as the first port of call for many patients in South Africa, whether or not one has medical aid or whether or not one can actually afford to go to the private sector. We find that patients do, despite not being able to afford, attend private practitioners for much of their medical needs. So I think family practitioners would play a huge role here. The other thing that I think would be of importance is, I think it would be important to discuss a private public health sort of approach to the funding of the vaccines, because if the vaccines are to be delivered to frontline workers, and frontline workers are healthcare workers, most of the healthcare workers are on medical aids. And perhaps one could think about the vaccines becoming a PMB. And therefore, if this is the situation, then there'll be more left in that purse for populations that can't afford. So it's something that I think we need to think about, and we need to engage with the department on. So I must also remind ourselves that we have huge social inequities in this country, and any vaccine rollout will actually be impacted by our social inequities. I mean, the pandemic itself highlighted our long-standing systemic health and social inequities. And if we're going to have a rollout, and we're going to look for high-risk people, and if we're going to have to go for a second dose, it's going to be much easier to do it in Sandton than it's going to be able to do in Khayelitsha and many other similar locations to Khayelitsha, speckled throughout our country, that is part of South African life. So when we have this limited initial supply of vaccine, and as we get more supplies, we are going to have to live with and face our realities and try to work out how we could try to deliver in the face of these realities. Now, talking about limited initial supplies of vaccines, it's not only for South Africa or the lower income countries, but it's going to be globally, because while countries have pre-purchased, manufacturers are not going to be able to supply the United States of America, for example, with enough vaccine for 230% of the population immediately. It's going to come out in batches and in tranches. So globally, we need to look at how we actually are able to manage our limited initial supplies of vaccines. So the World Health Organization has put together a SAGE values framework for the allocation and prioritization of the vaccines. And its framework takes into consideration a number of values, and you can see them outlined here: human well-being, equal respect, global equity, national equity, and for us, very important, we need to look at national equity. reciprocity, and legitimacy. We've had the National Academies of Sciences in the United States put together its framework in October, and more recently, the Advisory Committee on Immunization for the CDC also put together its framework. But if you actually tease out the most striking principles that come through all these frameworks are maximizing benefits and minimizing harm, promoting justice, mitigating health inequities, and promoting transparency. So this would work for us in South Africa and on the African continent as well. But what we find is that this is something that's easily understandable by the Western world, because what they've used is Western philosophical ideals to justify reaching these standards and norms. What we need in Africa is we need our African indigenous values and our Ubuntu principles that will assist to refer to, that will assist our communities understanding why certain groups will receive the vaccines and why certain groups won't, and why vaccine hesitancy actually must be nipped in the bud. And to start off with, I think a very important part of African indigenous values is captured so eloquently by Mbiti when he says, I am because we are, therefore I am. So the importance of community is so important. The Nguni saying, umuntu ngamuntu ngabantu, a human being is a human being because of other human beings. And these two actually bring forward the interdependence and interrelatedness that is, first and foremost and underlying everything that means being African. And this could very well justify having an approach of the greater good for all while protecting vulnerable individuals and groups in terms of vaccine access and also vaccine hesitancy. I need to protect you, and therefore I should take the vaccine and protect myself. There's also the African tradition of Lekgotla, which has been, over the many years in the past, where communities resorted to this type of process, where they would unpack issues to come to some common way forward, to some consensus. And most importantly, they did this with respectfully. And this could be likened to meaningful community engagement in our vaccine discussions. So the South African Medical Research Council, going through a normative process with the group, has come up with 4 pillars of values. And this is what is going to be looked at as well during the consultation that's being done in Africa next week. And the 4 pillars are affirming the humanity of others, survival of the community, social solidarity, and meaningful community engagement. So what do we mean by affirming the humanity of others? Basically, it means that allocation decisions must be for societal benefit and must promote common good. But it can only do that while respecting human dignity. Every person has equal dignity, worth, and value, and therefore allocation decisions must take this into consideration and must be non-discriminatory. Characteristics like ethnicity, nationality, race, religion, and so forth are not to play a role in allocation decisions. And this resonates so well with Section 9 of our Bill of Rights of the Constitution. Allocation decisions are to be impartial and to be in accordance with FAIR criteria. What do we mean by survival of the community? Allocation decisions must be based on best available evidence. You can't use a quack science. Communities, people can die. Also, essential service workers and those that contribute towards progress for preventing and treating disease are to be considered as essential for survival of the communities. In addition, those at greatest risk of severe illness and death could be included in priority groups because you would want our communities to survive. And in this way, you will find that benefits are going to be maximized and morbidity is going to be decreased and mortality would be decreased. And therefore, the communities would survive. What about social solidarity? Allocation decisions are to take into consideration the bonds that unify community, the interdependence that we have in community, the attachment to or the interest in others and their concerns, and the significant social, economic, and personal disruptions and hardships that our communities experienced before the pandemic and that they continue to experience during the pandemic. I think very important to take into consideration is that inequities increase among socially vulnerable groups during the time of pandemics. And also that vulnerability may, for the first time, emerge in certain individuals and groups during a pandemic. Why should we have meaningful community engagement? This is going to allow for a promotion of legitimacy and trust, which we're quite low on at the moment. And also ownership of allocation decisions. Community involvement is required not only for allocation decision making, but also to address vaccine hesitancy. Now, our decision makers have a huge challenge. They've got to not only regain public trust, but they also have to maintain public trust. And they have to become trustworthy. And how are they going to do that? They've got a chance now. There's the vaccine discussions that are coming to the fore now. And I think they should start, and I'm hoping that the release on the 4th of December is a first start towards ensuring early engagement with stakeholders. It's also important that decision-making processes are ethical and transparent. And for this, integrity, which reflects the need to act with honesty, reliability, and fairness, and a willingness to be held accountable to explain one's actions is absolutely critical. And it's critical now more than ever. I think many of you recently have been attending the webinars on corruption that have been initiated by several groups in the country. So we've agreed we're going to have limited supplies of vaccines. And if we get supplies for 10% of our population, it doesn't mean the full 10% will come through from COVAX immediately. It seems as if the vaccine allocation will be done in 3% tranches. So there's going to have to be a phased allocation. So who should we start off with first? Globally, the frameworks and the literature points to healthcare workers, to start off first with healthcare workers. How do we actually justify healthcare workers from our African indigenous approach, values approach? Our healthcare workers have instrumental value in terms of the pandemic response. They're at high risk of being infected But at the same time, they are responding to society's needs, and they're essential for survival of our communities. And therefore, they should be considered first. Whether they are paid or whether they are volunteer individuals serving in healthcare settings, if they have the potential for direct or indirect exposure, they need to get the vaccine first. Then what about other essential workers? And this would include healthcare, health providers in other fields as well. All those, the other essential workers are required because they're necessary for social solidarity, for upholding societal functioning. Who are these people? We're looking at teachers, workers in food supply chains, individuals working to upholding the economy of the country. For example, our bank tellers, policemen, those involved in transport. And could we consider politicians or decision makers? Because politicians are necessary as well for societal functioning. I know that there's so much distrust, but perhaps we need some discussion as to whether they should be prioritized as well. Then we look at adults with comorbidities, those over 65 years old. And as we get more results from research, we could look at children, pregnant women, etc. But I think the most important thing to remember is there is going to be a constrained supply. And because of this constrained supply, benefits of the vaccination will be delayed for many. But as supplies start increasing, eventually there's going to be enough for everyone else. So that's somewhat reassuring. What about vaccination implementation strategies? It's so important that one needs to consider this. So it's not just doing the framework and deciding on who the priority groups are. How do you implement? For us in South Africa, first and foremost is safeguarding the processes. And what do I mean by this? We need our checks and balances to ensure that those corrupt, greedy fingers are far away from the cookie jar, that those corrupt, greedy councillors who helped themselves to the food supplies for the poor and the needy don't help themselves to the vaccines first before those at high risk actually get the vaccines. So we've really got to ensure that corruption is safeguarded against when it comes to the implementation strategies. Then we've got to have the monies, we've got to have systems that are functional. What about storage? There's going to be issues around storage. I mean, certain vaccines can only be stored at certain temperatures, etc. Handling, distribution, uptake, etc. So it's, all this will feed into, if done correctly, will feed into a well-implemented vaccine program. And just to end up with what Tedros from the WHO had said, to quote, "The urgency with which COVID-19 vaccines have been developed must be matched by the same urgency to distribute them fairly." Now, he was speaking about it at a global level. For us, we need to look at it from within our country. We will have concerns about inequitable distribution because of the inequities we have within the country. But I think together, in solidarity between the public and the private sectors, we could have equitable distribution of the vaccines. And with that, I thank you for your attention.
Thank you so much, Ames. This was a wonderful presentation, and I think there's a lot of thought for, that we still need to go and digest of what you have said. And you will see Salma recently over the weekend, or I think it was Friday afternoon, released also our statement where we were cautioning National Department of Health to look at what is the best for our country, and can we really afford just to throw money into a pool. And, as we are not one of the higher income countries, but we are actually on the lower income. Ames, thank you so much for this. I'm going to ask, if we can maybe 5 questions and then go over to Prof. Madhi. Shelley, will you be ready to assist here, please?
Hi, Dr. Kutsia. Yes, sure. Thanks to everybody that's posted their questions on the Q&A. We've had quite a few technical questions coming through, which Prof. Dhai, if you don't mind, I'm going to leave for Prof. Madhi to answer, and then I'm going to focus the ethical questions for you. There was just one question of clarification, which we'll deal with first. In terms of the cost of the vaccines, or what South Africa will be paying over, is the 2.15 billion just for the 10% of the population? Is that correct?
Exactly. It's just for the 10% of the population. So, there's been this fever. We need to get the vaccines, but the cost of the vaccines is tremendous. And that's just for the vials. Add transport, shipping, storage, administration, etc. It's probably going to be double the amount. Yeah.
Okay, thanks for that. All right, then we also took a question, and this is specific to, I guess, research ethics. So the question came in terms of the vaccine race, certain fundamental ethical requirements have been relaxed or waived. Do you think that this may put lives at risk in the longer term?
So in terms of the ethical requirements, let's start from before the clinical trial. So while ethics committees have embarked on rapid review, it doesn't mean that the ethical principles have been relaxed. It's just that the processes have been expedited, but this has not been done at the expense of safeguarding participants against harms and wrongs. The South African Health Products Regulatory Authority as well has also reviewed, while rapid, also gone into quite a bit of detail in terms of safety issues, etc. So that's the one. Then we're looking at now the companies have, well, of course, they are throughout the research, there's the data safety monitoring boards that monitor the research itself and the results that come through. And once the results, and this is where the concerns arise, is because the results have been announced, but they're not peer-reviewed. And therein lies the scientific problems, in terms of statistical issues, etc. So here's the emergency use dilemma that comes to the fore. Do you actually now unblind everyone, okay, and roll out the vaccines on an emergency basis, knowing full well we don't know to detail the reactogenicity of the vaccines, we don't know the durability of the vaccines, we still have to monitor long-term for side effects, etc. Or do we continue actually with the studies and wait for peer review, etc.? And I think you can make an argument for rolling out the vaccines, but at the same time monitoring. to look at durability and long-term side effects. So there are ethical concerns. It is the emergency use dilemma, but it's a balancing act. Thanks. And I do not believe that ethical requirements have been relaxed. Definitely not in our country.
Thanks, Prof. Dhai. I see there have been a couple of questions related to that coming through now, so hopefully you provided some reassurance. Then there was also a question in terms of what's happened now, the ethics of conducting vaccine trials in a country like South Africa, but then South Africa not having surety of access to these vaccines ultimately. What are the ethical principles and ethical issues in that?
So the trials would not have been conducted if there wasn't an agreement for those that were participating in the trials to receive the vaccines, should the vaccines prove to be effective. So the clinical trial participants are covered. However, the country itself is not covered. And there's arguments for and against, because when we look at should the country, because it's allowed for the clinical trials to be conducted, should the country have access to these vaccines first? Remember, the trials are not only being conducted in South Africa, they're being conducted in many different countries around the world. So the proportionality rule will have to come in. If you've contributed so many participants to the trial, then maybe we could give you this proportion of vaccines. So these are things that need to be worked out. And yes, I think if we actually are conducting trials, then the proportionality rule should kick in terms of our access as well. So not only for the participants, but for others in the country. Over.
Great, thanks, Prof. Dhai. Then we've also had a couple of questions come through as the discussion has gone on vaccine refusal. So, what will be the rights and what will be the situation for those members of society, perhaps even who are identified in the earlier stages as recipients for the vaccine, but then who refuse to get vaccinated?
So, unless there's a regulation that makes it necessary, makes it mandatory that they take the vaccine, they can actually fall back on their constitutional right, Section 12 of the Constitution, which allows everyone the right to their bodily integrity. And if they make an informed decision not to take the vaccine, it cannot be pushed upon them. However, remember that we have a constitution and we forget to read Section 36 of the Bill of Rights, which limits every right, conditional to the limitation being reasonable and justifiable in an open and democratic society. So I think this is evolving. And I think the policymakers, the ethicists, the scientists will need to get together to see how vaccine refusal should be addressed as well. But most important, I think if someone refuses a vaccine, it's what do they understand about the vaccine? Have they been influenced by all the conspiracy theories that have been floating around? And therefore, it's really important for us to get out messages, proper messages based on scientific evidence in a language that our populations understand. So if they do make a decision not to take a vaccine, it's an informed decision based on evidence. Over.
Thanks. All right, so I think the last question for this session, and I'm sort of chosen this as the last session because, Prof. Dhai, you can feel free to hand it over to Prof. Madhi if this is slightly on the technical side for you. But there was a question with regard to the reference to local vaccine manufacture and Africa CDC initiatives. And this was in sort of reference, I guess, to the fact that the CDC initiative is going to depend on technology transfer to Africa recipients, which we know, has had its challenges in the past. And then this moved on to, do we think that perhaps, and there has apparently, I was not aware of this, been a proposal from South Africa and India to the World Trade Organization to waive intellectual property rights on COVID-19 health technologies? Would this not perhaps be a better intervention to pursue in the sort of COVAX and CDC discussions?
I think it's an excellent way to go forward. And yes, South Africa and India have initiated this and have actually approached it at the level of TRIPS. And it's fast catching momentum with other countries coming forward. So yes, I think there's got to be a lot of advocacy done for this as well. So it's not just a development thing or a relaxation of intellectual property rights thing. I think they all must be done in parallel. And I think, if we can get as much push for this as possible. There was a petition going around, several have appended their signatures to this, and I think that petition is still going around. So if people haven't signed, maybe find that petition and put your signatures on that as well. In terms of South Africa and capacity, yes, there is the BioVac that we have in South Africa, and its capacity is definitely going to be supported by the various departments. Definitely, I know from Department of Science and Innovation. So it can start getting more active in the vaccine development space. Over.
Okay. Thanks, Prof. Dhai. Sorry, I've received the message that Prof. Madhi is online, but he's having some sound problems. So I'm just going to pose one more question to you, which I know is about one of your favorite topics. So in relation to Ubuntu and traditional values, there were a couple of comments that came through on the questions that it seems that these values have been discarded even when it comes to preventative measures for COVID. How, and this is a very difficult question, how do we raise this national value up, even in terms of the other preventative measures that we've got in place?
So I think that's an excellent question, because what we've seen unfolding is lip service to Ubuntu. Even our decision makers will talk Ubuntu. But what have we seen? Even during the pandemic, their fingers were in the cookie jar. And I mean, this was a selfish approach rather than an approach in social solidarity. So what we need is, I think, an injection of our African indigenous values, back into Africa. Because it's not only South Africa. I mean, we have issues throughout the continent. And I think it's time we took a step back. We've become very influenced by Western ideologies. The first person ideology, the me, the I, the selfish interest. And I think it's best to go back to the Ubuntu values of interrelatedness, interdependence. I am who I am because of you. And maybe it's this time of the pandemic and the vaccines at which we can start injecting Ubuntu values back into our African way of thinking and forward moving. Over.
All right, thanks. I'm just going to one more question for you, Prof, and then I think we're going to see if we can hand it over. So there have also been quite a few questions in relation to this initial 10% sort of vaccine availability to the country. One of them in particular was, and we've got limited, I guess, information about, how long immunity from the vaccines is going to last at this stage. And the question really was, is there any point in only vaccinating 10% of the population nationally, and given the fact that we don't know how long the vaccine will last, is this going to achieve any level of herd immunity was the question.
Yeah, so I think it's going to actually be a huge problem in terms of herd immunity. You can't arrive at herd immunity with just 10% of the population. And there have been some figures that the scientists have used. And and if I can recall correctly, but I'd like Professor Madhi to actually correct me on this. I think if the vaccine is about 90 to 95% effective, you have to immunize at least 75% of your population. So as you go to lesser and lesser effectivity, you've got to vaccinate a higher percentage of the population. So 10% is not going to be anywhere near herd immunity. Also, the COVAX venture is 10%. Remember, over 2 billion. Then there's going to be discussions and negotiations with manufacturers, direct discussions. So maybe South Africa can cut a deal and get something at a real discounted price as well. But I think it's going to be, take a lot in terms of also looking at public-private partnerships where the public sector pays for its vaccines. Those on medical aids pay for their vaccines to free up those pennies to get into the purse, to buy more vaccines so we can reach the level of, the volumes of our populations to be vaccinated that could allow for herd immunity. COVAX is not the angel it's been made out to be, and it's not the be all and end all in terms of vaccine access. Over.
Thanks, Prof. Dhai. I see we're sitting with a total of 47 questions on the chat line now. But I'm going to have to, unfortunately, or fortunately, hand over to Prof. Madhi, who I believe is ready now. So we'll go through, and I'll try to, some of these questions that are overlapping, summarize as many as we can, and then we'll try to go back to the recipients or to the questioners if we can with some, with important questions. But I'm going to hand over to Dr. Coetzee now to introduce Prof. Madhi. Thanks so much.
Thank you so much. It was a wonderful hour, and I think an hour well spent. So let's go over to Prof. Madhi. And Prof. Madhi, we are extremely happy and grateful for you to be able to log onto the webinar. You had language problems, and as we know, that is why we are doctors. We always make a plan to try and sort whatever is coming our way. So I would like to introduce Prof. Shabir Madhi. Now, for all of you, if you wondered if we had the right person to talk about the clinical aspects of vaccines, wonder no more. Prof. Madhi is a professor of vaccinology in the School of Pathology at the University of Witwatersrand and the director of the world-renowned Medical Research Council, Vaccines and Infectious Disease Analytics Research Unit. Just want to make you aware that both Prof. Madhi and Prof. Ames is coming from the University of Witwatersrand. So in addition, Prof. Madhi is also the National Research Foundation Department of Science Innovation Chair in Vaccines Preventable Diseases. Prof. Madhi is a NRF A-rated scientist and co-director of African Leadership in Vaccinology expertise. ALIVE is the abbreviation. He chairs the National Advisory Group on Immunization in South Africa. He's a former president of the World Society of Infectious Diseases and the immediate past executive director of South Africa's National Institute of Communicable Diseases. Now, Prof. Madhi trained as a pediatrician and has participated in numerous research studies on epidemiology and the clinical development of vaccines. As one would expect, Prof. Madhi has been recognized throughout the world for his work. He received the European and Developing Countries Clinical Trial Partnership Award for Scientific Leadership and a Lifetime Award Platinum Medal from the SAMRC. In January 2021, Prof. Madhi will take up the position of Dean of the Faculty of Health Science at WITS, follow up on Prof. Martin Weller, and it is my single honor and privilege to welcome him here tonight. I think we have been tonight in the company of two very big academics. Prof. Madhi, over to you, and I wish you all the luck with your presentation. Thanks.
So thank you very much, and good evening to everyone, and apologies for the hiccups that I've experienced. Are you able to hear me fine?
Yes.
Correct. Okay. So what I'm going to do over the course of, hopefully it won't take too long, perhaps the next half an hour or so, is really touch on two issues. And the one actually follows up on some of the questions that were being directed to Ames. And that is, what is our current understanding in terms of natural infection? What type of immunity does it induce? And how long lasting is that immunity? And then I'm going to just give you sort of a broad overview in terms of COVID-19 vaccine development, and probably move forward with some of the discussion that Amy had started as well in terms of which vaccines would be most suited for South Africa. And one of the questions is, what percentage of the population, as an example, needs to be vaccinated for us to be able to achieve herd immunity or indirect protection? So as a start, I think this is data which is familiar to all of us, and probably very few of us require reminding in terms of SARS-CoV-2, the virus that causes COVID-19. And the manner in which the virus gains entry into the body is by way of what is known as the ACE2 receptors. Important to the virus are these proteins, and of particular interest to us in the field of vaccine development up until now is a spike protein. So the virus uses a spike protein to attach to the ACE2 receptors. It's internalized. And as all of you know, a virus, in fact, is not a living organism. It doesn't actually constitute the 7 requirements of what a living organism has. So it essentially needs to hijack the host cell and make use of the host cell machinery to replicate and to produce more viruses. These viruses are then released into the circulation, taken up by your antigen-presenting cells and processed within the antigen-presenting cells. What then happens is that different components of the virus is expressed by these antigen-presenting cells and presented to the T helper cells. The T helper cells then signal to the B lymphocytes and the CD8 T lymphocytes in terms of getting it to start differentiating firstly, and then proliferating. Now, these B lymphocytes essentially go on to develop into plasma cells that produce an antibody. And that antibody is of particular importance to us because our understanding is that those antibodies would then attach to the proteins, the spike proteins of the virus as an example, preventing the virus from adhering to the cells. In addition to which, often what these antibodies are able to do is, together with a complement system, result in lysis of the virus itself. Then some of these B lymphocytes go on to develop into memory B lymphocytes, and those are especially important upon re-exposure to that particular organism. Unlike the first time of exposure, where it takes between 7 to 14 days for these B lymphocytes to start differentiating and proliferating and producing antibody, upon re-exposure, if you do have memory B lymphocytes, those memory B lymphocytes can be stimulated and result in a very robust antibody response within a brief period of anything between 3 to 5 days, if not sooner. Now, in addition to the B lymphocytes, what's also important is the differentiation of your CD8 cells, your cytotoxic T lymphocytes. The cytotoxic T lymphocytes are especially important when it comes to destroying cells that are already infected with the virus. So we've got two components of the immune system, which we're really interested in. The one is known as a humoral immune system, which basically produces your antibody, and the other is known as the T lymphocyte immunity, which is largely dependent on the cytotoxic CD8 lymphocytes. As I mentioned, both of these work in consort with your T helper cells. Now, what do we understand in terms of natural infection? So over the past few months, there's been a number of publications in terms of indicating what we can expect when it comes to antibody responses. And this is one example where it shows that individuals that have had asymptomatic infection generally will have lower antibody concentrations than those individuals that have had symptomatic infections. In addition to which, those individuals that have had asymptomatic infections, there's waning of the antibody that as soon as 1 to 3 months later, 40% of them will actually be seronegative. In contrast, individuals that had symptomatic infection, only 13%, 87% will still remain IgG positive at about 1 to 3 months later. Now, what's important to recognize is that this isn't something that's unique to SARS-CoV-2. It's not uncommon for antibody to wane over time. And the absence of antibody doesn't necessarily infer the absence of immunity, because like I mentioned earlier, an important component in terms of the immune response to the virus is the establishment of memory B cells. So even if there is waning of this antibody, one would expect that if those memory B cells have been induced, that one would still have some level of immunity if one was to be re-exposed to the virus. And I'll come back to that just now. Now, in addition to the B lymphocytes, like I've mentioned, another important component is your T lymphocytes. And this is a study which basically looked at T lymphocytes in individuals that had recovered from severe illness, from asymptomatic or mild illness, shown in the olive color, including those individuals that were exposed but didn't test positive. In addition to which, they looked at blood donors from 2019. And those blood donors were obviously naive to SARS-CoV-2 in that the virus wasn't actually circulating at that point in time. What this basically looks at is different sort of T lymphocyte responses to different proteins of the virus, the spike protein, the membrane protein, and the nucleocapsid protein. What it shows intriguingly, firstly, is that even individuals who had donated blood in 2019, some of those individuals, in fact, do have some reactivity that's induced by the spike protein and the membrane protein of the SARS-CoV-2 virus. And the reason for that is that we do know that the SARS-CoV-2 virus shares some sort of epitope homogeneity with other common cold coronaviruses. So you have this sort of cross-reactive immunity, and what role that actually might play in terms of the severity of illness after someone is infected with the SARS-CoV-2 virus is as yet unknown. But what this data also shows us clearly is that unlike what we saw with antibody responses, the T lymphocyte responses is much more predictable in terms of its magnitude as well as the percentage of individuals that are exposed to the virus, independent of the severity of illness. So putting these two data points together in terms of antibody responses, if an individual has been exposed, even without testing positive, a large percentage of those individuals, 60%, would actually have antibody. And in fact, close on to 85 to 90% of them, despite just with an exposure without actually being infected with the virus, that exposure might be adequate to actually induce an immune response, including about 85 to 90% having T lymphocyte immune responses. Once you actually have confirmed SARS-CoV-2 infection, either asymptomatic or mild illness or severe illness, close on to 100% of those individuals will have T lymphocyte immunity that is induced. Now, what this data basically shows us, this is a recent publication that hasn't yet been peer-reviewed. It's currently undergoing peer review, but it's been sort of shared in the public domain. And what this basically looking at is looking at the immune responses, in particular the IgG responses to the spike protein to the nucleocapsid and what is known as the RBD, the receptor binding domain. Now, the receptor binding domain is especially important for a spike protein. It's a component of the spike protein, and it's that component of the spike protein that's able to attach to the ACE2 receptors. So if we've got antibody that is targeted specifically to that component of the spike protein, we would expect that antibody to prevent infection from occurring, or at least prevent the virus from infecting the human cells. Now, what you see on your right-hand lower corner is what is known as neutralizing antibody. So it's good to produce antibody, but what's also important is that that antibody needs to be functional. And we're able to measure the functionality of this antibody. Generally, what the data points towards is that although there's some heterogeneity in terms of the immune responses following infection, what happens is that the half-life of the antibody ranges anything between 67 to 68 days for the RBD IgG and the nucleocapsid IgG to up to 100 days for the spike IgG. So your half-life of antibody seems to be for at least 2 to 3 months. And in this study, what they were able to do was follow through individuals that had been infected right into 6 to 8 months later. And as you can see, the dotted line, the green dotted line, basically shows you the lower limit of detection of the antibody. And even by 8 months, the majority of individuals, greater than 90%, would actually have antibody that's still detectable to the RBD, to the spike protein, as well as the nucleocapsid. And much of that antibody, as you can see, is actually functional. So it's antibody that would assist in terms of the killing of the virus. Now, in addition to that antibody, what we also see, and in fact, much more optimistically in terms of the duration of immunity, is when looking at the presence of the SARS-CoV-2 memory B cells, as well as CD4 and CD8 T lymphocyte memory cells, what we see is that the majority of individuals, even if there might be waning of antibody, still have these memories T lymphocytes, B lymphocytes, as well as CD4 and CD8 lymphocytes. And those are especially important, like I mentioned, in terms of reinfection and what to expect if an individual, in fact, does become reinfected. In the presence of this sort of memory B cells, as well as CD4 and CD8 cells, what one would expect is that even though it might not be adequate to prevent reinfection, what it would do is that it would attenuate the clinical cause of the illness. So individuals that become reinfected would be less likely to develop symptomatic illness, and certainly very much less likely to develop severe disease following an initial episode of infection, because the reason you've recovered from that initial episode of infection is because of your immune system having mounted an immune response. Also important in terms of the B and T cell memory responses is that there doesn't seem to be as much difference compared to the antibody in terms of the concentration between those individuals that were hospitalized and non-hospitalized for COVID-19. So it seems that your memory B cells, your CD4, CD8 memory responses are much more predictable, and more than 90% of individuals, again, would have these sort of memory cells at least 6 to 8 months after having been infected with the virus. Now, the question is whether natural infection actually does protect against reinfection. And many of you would have heard of the few cases of reinfection that have been reported. Now, these are data from non-human primates, a rhesus macaque, infection-reinfection challenge model. And what these data basically show us is that following a natural infection in these macaques, both in the upper airways as well as using bronchoalveolar lavage to see what's happening in the lung, is that you have ongoing shedding of live virus up to 8 days and beyond. But when these macaques are re-challenged about 3 to 4 weeks later, after having recovered from the initial episode, we find, in fact, the shedding of the virus both in the upper airways as well as its identification in the bronchoalveolar lavage is very much attenuated. In fact, there's very little virus that actually replicates upon a re-challenge. So using non-human primate data, it indicates that an infection does actually induce immunity, and that immunity does protect, if not totally against reinfection, it would protect against prolonged infectiousness, as well as the ability of the virus to actually replicate in the lower airway. So to summarize in terms of our understanding of natural immunity does induce both the humoral as well as cell-mediated immunity. The humoral immunity probably persists for at least up to 6 months, perhaps slightly shorter in terms of antibody presence, but the memory B lymphocytes persist at least through to 6 to 8 months. Following an infection, natural infection, a person can get reinfected. That really depends on the amount of virus that's circulating in a community. As an example, probably 1/3 of adults are reinfected annually with influenza. And that's not just because of the drift of the virus, but simply people become reinfected. But the reason why 1/3 of the adult population don't become symptomatic with influenza when they're reinfected is because the body is able to mount an immune response that attenuates the clinical cause of that reinfection. So it shouldn't come as a surprise that the same thing wouldn't hold true for SARS-CoV-2. Reinfections will occur. But simply considering what's happening currently in Europe, where they're going through a resurgence, as well as in the United States, when you consider how few cases of reinfection have been reported in the presence of the tremendous amount of infection that's currently taking place, it sort of lends credence to the concept that reinfections generally will either be asymptomatic or result in mild illness. As I mentioned, the data currently suggests immunity, at least the memory responses being lasting for at least 6 to 8 months. And obviously the reason we haven't gone beyond that is because virus has only really been studied for the past 9 to 11 months. When we look at other common cold coronaviruses, though other cold coronaviruses induce immunity that probably lasts for at least 2 to 3 years. So not necessarily lifelong, unlike measles infection, which usually confers immunity that lasts over 40, 50 years. With a common cold coronavirus, it might not be that long. So I'm going to now briefly touch on COVID-19 vaccines. And I think most of you are familiar in terms of the different stages that we go through when trying to develop a vaccine. We start off in a preclinical testing, then usually start with phase 1, phase 2 studies before going to phase 3 studies. Now, what we have seen happen with COVID-19 vaccines, it was what usually takes about an average of 10.5 years in terms of vaccine development. From the time it goes into preclinical studies to the time it's licensed, that duration in terms of vaccine development has really been condensed into literally less than a 10-month period. And that has been really a phenomenal achievement. And at the start of this, a few months ago, had you asked any scientists, are we going to have a vaccine and how many vaccines will we have by the end of 2020, very few would have ventured that you were going to have at least 3 to 4, if not 5 vaccines that will already show efficacy by the end of 2020. And this has been really a spectacular achievement in the field of vaccinology. Now, the reason why this has actually happened is that unlike the tradition of moving from one phase to another and actually having a pause in between those different phases, what we see happening with COVID-19 vaccine development is many of these phases have actually been taking place in parallel or have started and almost immediately thereafter, we've started to another phase of clinical development. And that has really allowed an acceleration and cut the time period between these different phases in terms of vaccine development. Where we stand currently is that there's close on to 40 vaccines that have now gone into human clinical trials, including 11 vaccines that are currently in late stage phase 3 studies and 14 vaccines that are in phase 2 studies. And these phase 2 studies can give you an early readout in terms of whether those vaccines protect against COVID-19 or not. The reason we have these large phase 3 studies with a sample size going 30,000 to 40,000 is not so much just to look at the efficacy of the vaccine. Looking at the efficacy of the vaccine, depending on how much infection is taking place in the community, you could probably get an answer, as we would probably in South Africa, by enrolling 2,500 to 5,000 individuals. But to be able to detect extremely uncommon side effects of the vaccine, then you need to have numbers into the tens of thousands. And that's the reason why these vaccine studies have 30 and 40,000. It's not to see whether the vaccine necessarily protects against COVID-19. You can achieve that with a smaller sample size, but it's really to determine what is the safety profile and in particular try to pick up on extremely uncommon side effects of the vaccine. Now, another reason why we've seen a rapid development in terms of vaccine is that what's happened is that technology that has largely never been used before for the development of vaccines has been deployed for the development of COVID-19 vaccines. And the two technologies in particular, the one is the nucleic acid-based technology, which is your messenger RNA and DNA vaccines. And the two that are known to all of you by now is the Pfizer vaccine and the Moderna vaccine. Now, the messenger RNA, and I'll describe briefly what it really looks at, has never previously been used. There's no vaccine that's been licensed to date using the messenger RNA vaccine. The other relatively new technology is your viral vector-based vaccine. Now, the example of this is the AstraZeneca vaccine. And again, there's only one vaccine that has to date been licensed using the viral vector-based approach. And that, in fact, is an Ebola vaccine that was used in West Africa during the Ebola outbreak. And that vaccine was actually just licensed during the course of this year. So these are relatively new technologies. But the reason why these technologies are so adaptable and you're able to sort of use it to develop new vaccines is that all that it really requires is the sequencing of the pathogen of interest. So once you've sequenced the virus, as an example, and you've identified which component of the virus is of interest to you, you take that genetic material that codes for that component of the virus, and you're using that as a vaccine. So I'll describe that just now. The more traditional approaches is your subunit vaccines, and there's one that's currently in phase 3 study, and then you've got your live attenuated and inactivated vaccines. So examples of your live attenuated vaccines are your measles, mumps, rubella, your inactivated vaccine, your inactivated polio vaccine as an example. These are just examples. So we're using 4 different technologies that have, at least 4 different technologies have been used to try to develop a COVID-19 vaccine. And this is just I'll go into the detail on each of these. Of these 4, 10 of these vaccines have now gone into phase 3 studies. The 2, which I referred to, the messenger RNA vaccines, have now basically completed at least efficacy readout. And as you now know, the United Kingdom has been the first country to actually license, at least for emergency use, the Pfizer vaccine. And very soon we'll probably see the Moderna vaccine follow as well. In addition to which, I just saw today that the AstraZeneca vaccine is likely to be licensed or at least get the EUA, emergency use authorization, in the United Kingdom as well as in India. And then we've got other vaccines that are currently still in evaluation as to whether they protect against COVID-19. So I'm going to touch briefly on each of these vaccines just to demonstrate what is different about these vaccines. And the endpoint of all of these vaccines is very similar in terms of what you're trying to induce when it comes to the immune system. You're trying to get that component of the virus which is of interest to you to present itself to the T helper cells and then to result in a differentiation and a proliferation of your B lymphocytes and your cytotoxic T lymphocytes. And those go on to develop either plasma cells producing antibody or go on to develop into memory cells. So with the whole cell virus, there are 4 vaccines that are currently in phase, or 3 vaccines that are currently in phase 3 studies. Included in this is a Sinovac vaccine, which is an inactivated whole cell vaccine that is currently in phase 3 studies in Brazil. And they expect to release data from that study as well, probably before the end of this year. And then you've got the live attenuated whole cell vaccines. Now, as you can see, the 3 studies that are in phase 3, but we're still waiting results from this. One of the concerns of the whole cell approach is that in addition to producing antibody, which is neutralizing, so functional antibody, when you're using a whole cell, you're obviously allowing for a much broader repertoire in terms of the immune response to different components of the virus. And it might be that you end up producing antibody that doesn't necessarily neutralize the virus, but can paradoxically result in increased susceptibility to developing severe disease. Now, this is a theoretical concern. We obviously don't see it with inactivated polio vaccine as an example, but it is a theoretical concern that people proposed previously for all of the vaccines, but perhaps most so for the whole cell virus, the whole virus vaccine approach. So with the gene-based vaccines, all that you're doing is you're taking the genetic material, and in the particular instance of Moderna and Pfizer, the genetic material that codes for the spike protein. That is injected into the muscle, and then it uses the muscle cell machinery to produce the protein. that protein is released into your circulation, taken up by antigen-presenting cells. And again, we're wanting it to induce a similar sort of immune response, but in a much more predictable manner than what is induced after natural infection. As I mentioned, 2 vaccines that have now shown efficacy, the Moderna vaccine and the Pfizer vaccine, and we'll come back to those just now. Now, looking at antibody responses, and this is important in terms of what to expect after a single dose of vaccine and after 2 doses of vaccine. And I've highlighted in a red box the dosing that's been used now that was used in a phase 3 study. And what it shows us is individuals who were vaccinated at day 1. By day 21, you find that there was a significant increase in terms of antibody targeted to the S1 binding site, the spike protein. And following a booster dose, both in individuals between 18 to 55 years of age, as well as between 65 to 85 years of age, following a booster dose of vaccine, you get anything up to about an 8-fold increase over and above what you got after the primary dose of vaccine. And the antibody concentrations after the booster dose, right on your extreme right-hand side, is antibody concentrations that's identified in the individuals that recovered from COVID-19. And you find that antibody responses after a booster dose of vaccine is 10 to 15-fold higher than what is induced following natural infection. So this is just looking at antibody. A more important measure is to actually look at the neutralizing antibody, the functional antibody. Now, when it comes to the neutralizing antibody, we see a slightly different picture with these messenger RNA vaccines. In that after the first dose of vaccine at day 21, before they're getting the second dose of vaccine, in fact, you find very few individuals that actually have got neutralizing antibodies. So a single dose of the messenger RNA vaccine, irrespective of age, doesn't seem to induce too much by way of neutralizing antibody after the primary series. But as soon as you give the booster dose of vaccine, then you've got a marked increase in terms of neutralizing antibody. And again, it far exceeds the neutralizing antibody that one observes in individuals that have recovered from COVID-19. So with the messenger RNA vaccines, looking at the neutralizing antibody kinetics, one would expect that you do require at least 2 doses of vaccine to get protection against COVID-19. So the viral vector approach, now this, like I mentioned, is a new technology. It uses viruses to which humans are of very low pathogenicity to humans, or that are actually completely foreign to humans, but known not to cause infection in humans. Now, what happens here is that a genetic material of interest, and again, the genetic material coding for the spike protein as an example, is inserted into this virus. And the virus is used as a vector to now deliver that genetic material into the host cell. Once in the host cell, the virus is degraded, the genetic material is released, and again, similar to what we saw for the nucleotide-based vaccines, the host cell now uses the information of that genetic material to produce the proteins which are released and taken up by the antigen-presenting cells. So the vaccines that have been used using this approach is the AstraZeneca vaccine, which uses a chimp adenovirus vector-based vector. And then you've got a vaccine that's been developed in China, which basically uses a dual approach of adenovirus type 5 and adenovirus type 26 approach as a prime boost strategy. And then you've also got a Johnson & Johnson vaccine, which uses an adenovirus type 26 as a vector. And all of these different vaccines that are pointed out here are now in phase 3 studies, with AstraZeneca having reported on the efficacy readout, and the Johnson & Johnson vaccine expected to provide an efficacy readout probably late this year or early next year. So what do we see in terms of immune responses? And I'm just going to look at the AstraZeneca vaccine following an initial vaccine. What we see is antibody responses, which are boosted with a second dose of vaccine given at day 28 in this particular study. Now, the concentration of antibody that's induced is sort of comparable in this instance to what is actually observed in individuals that have recovered from COVID-19. Like I pointed out, when you look at individuals that recover from COVID-19, those individuals with more severe disease generally have a much higher antibody concentration. And in fact, with this particular vaccine, the antibody concentration, even after the booster dose of vaccine, is probably slightly lower than what is induced in individuals that have recovered from after severe infection, but in the ballpark of those individuals that have recovered from a mild infection. Looking at the neutralizing antibody, unlike what we saw with the messenger RNA vaccine, a single dose of the vector-based vaccine does induce neutralizing antibody. But again, following the booster dose, we get a substantial increase in that neutralizing antibody compared to after the primary dose. So with adeno-based, with this particular vaccine, it induces an antibody response after a single dose, including neutralizing antibody, and you get a boost after a second dose. And this sort of antibody response, again, is independent of age groups. These are data looking at different age groups, 18 to 55 years, 56 to 69 years of age, and looking at one dose as well as two doses. And what the study also did was looked at two different dosing concentrations, a low dose group and a standard dose group. Now, what you see interestingly is that there is potential for this to be a vaccine with a dose sparing schedule, in that the antibody responses after, and this is actually looking at the neutralizing antibody responses after two doses of the low dose formulation is almost identical compared to the antibody concentrations after two doses of the standard dose. What you see, the dotted lines are individuals that only receive a single dose of vaccine, and it clearly points out that the booster dose does result in increase in terms of neutralizing antibody. So last but not least are your protein-based vaccines. And one vaccine that is currently in phase 3 studies, the Novavax vaccine, which is also being evaluated in South Africa. So all of you are familiar with protein-based vaccines. Those are your diphtheria, tetanus, pertussis, acellular examples of your protein-based vaccines. And here it's a much more traditional approach. You're actually injecting the antigen of interest into the host that's taken up by your antigen-presenting cells. And that is aimed to elicit the type of immune responses that we desire from all of the vaccines. So when looking at the antibody responses, again, the neutralizing antibody responses, what we see with the protein-based vaccines, and particularly the Novavax nanoparticle vaccine, is that a single dose of vaccine actually does induce neutralizing antibody. But there's a substantial increase following the booster dose again. The booster dose in this particular instance is given at 3 weeks, and I've highlighted the dosing concentration that is being evaluated in a phase 2 and phase 3 study of this particular vaccine candidate. What you also observe is that the neutralizing antibody concentration after the booster dose of vaccine is sort of in the ballpark, or perhaps just slightly lower than what is observed in individuals that were hospitalized for COVID-19, but substantially higher than individuals with outpatient symptomatic illness that recovered from COVID-19. So what do we know currently in terms of the vaccine efficacy? The vaccine efficacy has been reported both for Pfizer and Moderna is in the region of 95%. For the AstraZeneca vaccine, inadvertently, we've got a range in terms of vaccine efficacy, ranging anything from 62% to 90%. The 62% is for individuals that receive 2 standard doses of vaccine. The 90%, oddly enough, is for individuals that received a low dose as a priming dose and then a standard dose as a booster dose. The study wasn't designed for that purpose. This was something that happened completely almost by accident in a sense, but a significant percentage of individuals, about 3,500 participants, ended up receiving this low dose, standard dose combination in the United Kingdom, and consequently they were able to fortuitously analyze whether there was actually vaccine efficacy for the particular dosing schedule. Now, these vaccines differ in terms of the cold storage requirement. The Pfizer vaccine needs to be stored at minus 70 degrees Celsius. It's got a shelf life of about 5 days. The Moderna vaccine, fortunately, can be stored at around about 2 to 8 degrees Celsius, and it's got a shelf life of about a month. So that provides some sort of competitive edge over the Pfizer vaccine in terms of deployment. The AstraZeneca vaccine, fortunately, can be again stored at 2 to 8 degrees Celsius, and it's got the shelf life much longer of 6 months. What we see in terms of the likely pricing of these vaccines is that the pricing is going to differ substantially. The AstraZeneca Oxford vaccine is probably 1/10 of the price of the Moderna vaccine, and these are prices per dose. The Pfizer vaccine is expected to come in at $20 per dose, the AstraZeneca vaccine at $3 to $4 per dose. Now, the other major challenge with your messenger RNA vaccines is the ability to scale up manufacture. Pfizer and Moderna estimate that they would, by the end of 2020, be able to produce 50 and 20 million doses of vaccine respectively. In contrast, AstraZeneca, which has now got 6 to 10 manufacturing plants that are already producing vaccine, expect to be able to produce up to 200 million doses of vaccine by the end of 2020. By the end of 2021, Pfizer expects 1.2 billion doses of vaccine, Moderna 600 million doses of vaccine, and AstraZeneca 3 billion doses of vaccine. So AstraZeneca aims to be able to produce more vaccine than Pfizer and Moderna combined. So what can we expect of vaccines? So the data that's been published up to now is about vaccines protecting against COVID-19. The big question is whether vaccines are actually going to protect against infectiousness and against people spreading the virus. So we don't have that data in humans as yet, but there is this Novavax study which was evaluated in macaques, where the macaques were vaccinated and then challenged. And we looked for replicating virus both in the upper airway as well as in the lung using bronchoalveolar lavage. And what this data basically indicates is that 2 doses of the Novavax vaccine induce good neutralizing antibody, 100% on your left-hand side, you see the extent of the neutralizing antibody compared to convalescent sera of people that have recovered from COVID-19. But importantly, upon challenging these macaques, after vaccination, you don't find any virus replicating either in the upper airway or in the lower airway. So there is some potential that these vaccines, in addition to protecting against COVID-19, could also protect against infection or at least attenuate the clinical cause of that infection and reduce the infectiousness of the individual. Now, I think Ames probably has discussed this already, so I'm just going to touch briefly. The challenge we face right now is that more than 50% of the initial global supply of vaccine that's going to become available by the end of 2021 has already been purchased in advance by high-income countries that represent 13% of the global population. And to give you sort of a different type of picture in terms of where all of these vaccines would go, as you can see, much of the initial vaccine that's going to be produced is going to end up going to the EU states, to the United States, to Britain, Japan, and a lot of vaccine is going to go to India. And the reason for that is because India is going to be manufacturing 2 vaccines, and that is the AstraZeneca vaccine and the Novavax vaccine. And in India itself, Serum Institute of India have indicated that at least 50% of all of the vaccine that will be manufactured in India will be for the Indian market. But it is really that Indian manufacturing facility that is going to allow for most of other countries not listed here to eventually be able to gain some access to vaccine, at least by sometime during the second quarter of next year. Now, why do we find ourselves in this predicament in Africa? And the answer is simple, is that we have never invested in terms of vaccine manufacture. So global, in the whole of Africa, there are 3 countries that produce vaccine. The one is Senegal that produces limited quantity of yellow fever vaccine. Egypt produces some basic DTP vaccine, and Tunisia produces some BCG and rabies vaccine. In South Africa, we haven't produced vaccine since 1992, when the vaccine manufacturing facilities were dismantled. So before 1992, South Africa actually used to produce vaccine, including measles, including DTP, including polio. We used to manufacture vaccines, but all of those facilities were dismantled. And since then, no vaccine has been produced in South Africa. Now, many of you will have heard that there's a local company that has got rights to eventually produce a vaccine that's being developed by J&J, the adenovirus type 26 vaccine. But the reality is that with the complexity in terms of vaccine manufacture and to set up the facilities and have everything authorized by SAPRA, there's no way that any local company is going to be able to reach that milestone in 12 to 18 months. So for the next year, we're very much dependent on being able to access vaccine from global partners. Amy has discussed COVAX facility and the limitations. South Africa has only signed up for 10% of vaccine, for enough vaccine for 10% of its population from the COVAX facility, largely because, unfortunately, South Africa is an upper middle income country. And the COVAX facility is structured in such a way that the purpose of it is for there to be cross-subsidization to allow for equitable distribution of vaccine, including cross-subsidization of low-income countries. South Africa, being an upper middle-income country, is expected to pay the same price as the United States or anywhere else. And consequently, because of the huge demand of it in terms of funding that would be required, it isn't actually able to commit to purchasing vaccine for at least 20% of the population. The 2.8 or 3 billion rand that has been now sort of committed, where just about 15% of that has been paid as a deposit, would only be adequate to purchase vaccine probably for about 10% of the population, as you've heard. So in conclusion, I think when it comes to natural infection, we can start breathing with some relief in that natural infection for people that have recovered probably does induce immunity. And we don't know exactly whether that immunity is going to last you for 5 or 10 years, but it's very likely that immunity is going to last you for at least a year. As I mentioned, this immunity is both humoral immunity as well as T lymphocyte immunity, and it's important in terms of preventing progression of infection, reinfections to illness and to severe disease. The experience with the COVID-19 vaccines can't be described as anything else but spectacular in terms of its high efficacy. But we also need to pause in that we need to understand that having a vaccine with 95% efficacy, which you're not going to be able to afford to buy large quantities and which will only become available to you in the year 2022 after the pandemic has likely passed, doesn't serve much public health value. In contrast to even a vaccine that has got 60% efficacy, if you can in South Africa get 60% of your adult population vaccinated with such a vaccine, together with a high force of infection that has already induced natural immunity, we could probably reach herd immunity, even with that type of a vaccine. So when looking at which vaccine and which vaccine should we be choosing from, it's not just about the efficacy, it's also about how deployable that vaccine is, it's about the price of the vaccine, is how soon you can get access to the vaccine, and what sort of quantity of vaccine you would actually be able to get to make a material impact of the pandemic in the immediate future. So until then, just a reminder that right now we don't have vaccine, and the only thing that's going to assist us in terms of the resurgence, which is sort of already imminent and already started in the Eastern Cape and Western Cape, is for us to continue adhering to non-pharmacological interventions. So thank you for your attention.
Thank you, Prof. This was a mouthful. I think we have a lot of, again, as with Prof. Ames' presentation and with your presentation, there's a lot that we still need to learn. There's a lot that we have to think about. And we also need to make sure that the logistic problems in our country, as well as the corruption, be addressed, because it's no use that we pay all this billions of rands and we cannot actually give a good service to our people in the end of the day. Without any further ado, Prof, I'm going to ask Shelley to go on to the question and answers. And then after that, I will ask Dr. Mazukwa to please thank you and Prof. Ames for this wonderful webinar, and also everyone of you that attended and is still attending. Please do not drop off. Please listen to the questions. And I think that is a way for us to learn. But again, thank you so much from my side for this wonderful, wonderful presentation from both of you. Thank you so much.
Thanks, Dr. Coetzee. Thanks very much for that, Prof. Madhi. We've also been receiving a number of questions. I've tried to kind of lump them together. There have been a couple of overlaps, but there's many and diverse questions. Unfortunately, we're not going to be able to get to everything. But what has come up a few times, which probably is, I guess, fundamental to people's understanding or going forward with the vaccines, is, are there multiple strains of COVID-19? And do we have an indication, if that's the case, that the vaccines that have been developed now will still be effective?
So there's only one single strain of SARS-CoV-2. There are some mutations that have been identified with a spike protein, but fortunately those mutations are not actually mutations at the RBD, the receptor binding domain. So from a vaccine perspective, where we're trying to raise antibodies specific to the RBD, the receptor binding domain, it's unlikely that those mutations are going to have a material effect on the efficacy of the vaccines. So it's a single, there's only one strain with some minor mutations. Those mutations might actually increase the infectiousness of the virus, but is unlikely to impact on the efficacy of the vaccine.
Thanks. And then during Prof. Dhai's talk, we had quite a few questions regarding sort of the persistence from, after vaccination, the persistence of immunity. And that now during your talk has now converted into, if we have patients who either have been infected, confirmed, or have antibodies, would they still be candidates for vaccination?
Well, we don't know if there's going to be an added benefit for them to get vaccinated. But I think if someone has recovered from COVID-19, there's probably less of a need to be vaccinated, especially if there's limited supply of vaccine. But that being said, it's not that we're going to be testing individuals to see if if they were previously infected before we vaccinate. That wouldn't be logistically feasible, in addition to which like I mentioned, there is waning of antibody, and more so when you're using the rapid antibody test. So you can't sort of be screening individuals to see if they've been previously infected to decide if they need vaccine or not. But if a person was confirmed to have been previously infected, there probably is a lesser need for that individual to be vaccinated in the immediate future.
Thanks. And then we've also picked up quite a few questions, I think, with regard to safety and adverse effects. So there was a general question here: are there any contraindications to receiving the COVID vaccine? Then additionally, there's been a question here with regard to, have any cases of vaccine-triggered arthritis been described? And then there was another one: are there risks reported of a possible cytokine storm reported in response to the vaccine? Sorry, so that's three questions in one.
Yeah, so I'll take the last question first, the cytokine storm part of it. So important for many of these vaccines was an interest as to whether it induces a Th1 or Th2 dominant immune response. And a Th1 dominant immune response is what you aspire to. And almost all of these vaccines have now been shown to induce a favorable Th1 dominant response without what you call the cytokine storm. It's actually quite well-regulated immune response. Unlike natural infection, you're much more predictable in terms of what you're going to induce with immune responses with a vaccine. So in terms of side effects, what needs to happen with all of these three studies is for the data to be released in the public domain, and hopefully in the course of the next 2 to 3 weeks, we'll see the studies being published in the scientific literature, in the NEJM, as well as in the Lancet. And that will give people a detailed insight in terms of the safety profile of the vaccine. Right now, the vaccines haven't been tested in pregnant women, so we can't make a recommendation for its use in a pregnant woman. Those studies are about to start. Beyond that, there isn't any other contraindication either for messenger RNA-based vaccines or for the vector-based vaccines, especially the inactivated vector-based vaccines. If you're using a live attenuated or a live vector-based vaccine, obviously individuals that are immunocompromised, it might be a challenge. But the vaccines we're currently discussing are not live attenuated vaccines. They're not live vector-based vaccines. They're inactivated vector-based vaccines. So immunosuppression, in fact, obviously that's an important group to be vaccinated because they're the ones at greatest risk of developing severe COVID. What was the first question? Does it cover all three questions?
Yeah, so it was related to the second question was then vaccine arthritis, which I'm not sure we have the data for.
So right until now, there hasn't been any report of sort of autoimmune type of phenomena following vaccination. But again, like I said, these studies have included 30,000, 40,000 individuals. For some extremely uncommon side effects, they will only materialize once millions of individuals have actually been vaccinated. And then sometimes it becomes a challenge to attribute as to whether it is due to vaccination or not.
Okay. And the first part was, are there any specific contraindications?
No.
Then coming back to some of the questions we received during Prof. Dhai's talk, will we be, and so this is now related more to the program and less to the technical issues of the vaccine, are there plans to try and incorporate the SARS-CoV-2 vaccine into the pediatric schedule for SA, or how are we going to ensure the uptake in the pediatric population?
Right. So right now, so just like the vaccines are currently about to be evaluated in pregnant women, there's also a clinical development plan for the vaccines to be evaluated in children, and including children as young as 5 to 12 years of age. So as we know, COVID-19 fortunately doesn't cause severe disease in children. But there is some concern that especially children older than 10 years might be important in terms of transmission of the virus, or at least is equally important as adults, and especially within the same age group. So there isn't an urgent need for vaccination of children, but those studies are about to start, looking at immune responses and safety of the vaccine in children.
Okay, so for now, it won't be, children won't be the focus, in other words, of the vaccination initiatives.
Certainly not, because there's no country in the world that's going to have enough vaccine to target children right now.
Okay. Then another one that we got to repeat, several repeats of this question is why is there such a difference between the prices for the mRNA and the adenoviral vector vaccines?
Well, the type of technology it uses is very different. And the vector-based vaccine uses much more simple, in a sense, technology, not if technology is ever simple, but it's the type of technology that's being used. The messenger RNA, like I said, is a completely novel type. The vector-based vaccines, this platform and technology has been in the pipeline for the past 10 to 15 years. So it's not a new technology. It's the first time it's been successful. Other than for Ebola virus in terms of showing protection. But with the messenger RNA, this is completely new technology. So setting up the facilities and what's required, I'm not a technician, but setting up the facilities to develop these sort of vaccines is very different. In addition to which, unlike AstraZeneca, which has indicated that they will be selling vaccine at no profit during the course of the pandemic, Moderna have been very clear that they will be making a profit of the vaccine.
Okay, thanks. And then this is a very interesting one. I think it's something that could unfold practically. Would you be able to vaccinate an individual with the first dose of the AstraZeneca, so in other words, the adenoviral vaccine, and a second dose then of an mRNA vaccine later on?
Theoretically, yes, but those studies have not been done to be able to give a definitive answer. But theoretically, because you basically, in a sense, boosting with the protein in one way or another, essentially you should get that boost with the heterogeneous second vaccine. But right now, like I said, I don't think anyone is going to be going that route.
All right, thanks. I think we've run out of time now. Thanks everyone for your questions. I'll try and summarize some of those that we haven't been able to get to, because there were quite a few sort of specific questions regarding immunodeficiency diseases, etc., which I think we'll at least try to come back to, or try to have Prof address. So with that, thank you so much, Prof Madhi and Prof Dhai, for the interesting talks. We're getting some quite good feedback here on the Q&A sort of panel here. I'm going to hand back over to Dr. Mzukwa to close the meeting. Thanks so much.
Thank you very much, Shirley, for that conclusion. I'm very privileged and honored to be given this opportunity to thank our panelists, our speakers, Prof. Ames Dhai and Prof. Shabir Madhi. Thank you very much for your great insights in the topics that you have chosen to speak on. And I am very sure that all of us have benefited and continue to benefit from your expertise. And very thank you to our moderator, Shirley Madhi, for this wonderful opportunity to moderate for us in this session. And again, to the summer board members who are in attendance, we really appreciate your presence. our members for attending and their loyal support to the association. And also we thank the non-members for joining, our colleagues who are not members of SAMA. We really appreciate your attendance and also joining us and sharing this information. And last but not least, we really would like to thank SAMA staff members who are working behind the scenes to see this come to fruition. And we really appreciate that. And with those few words, I would like to thank you, all of you, and I'd say have a great, peaceful night. And till we meet again, God bless you. Thank you.